and we want to start on time, and we'll continue to let folks in as they join us. We have a robust registration list, but welcome everybody. I'm Susanna Massarda, CEO for the Community Liver Alliance. We welcome you to our Hepatitis B update with Dr. Liz Zehng from the University of California, San Francisco Medical Center. And we're going to present on all things hepatitis B. I want to ask that you mute yourself. Unless you want to ask a question, you could put questions in the chat, and we have moderators to pay attention to those questions. And the Community Liver Alliance is a national nonprofit patient advocacy organization supporting the liver community through prevention, education, and research. And we know that we have a global presence serving the broader liver community. We reached over 30 countries through our educational mission to both providers and patients. We do keep our support community-based, and we ensure that the majority of the funds raised are invested into the local communities in which we serve. And we also focus on forging partnerships and collaborations, because that's really the strength of the Community Liver Alliance is our partnerships and collaborations. And we are excited to have you on our call today. And we know the need is great in liver disease. We know that liver disease is one of the nation's fastest growing serious health concerns, that 1 in 8 Americans are affected by liver diseases, and that liver cancer is one of the few cancers on the rise. And the fatty liver NASH affects 80 million adults and children in the US, and it's the #1 reason for transplantation. And we know that there are over 100 separate liver diseases, so we sure all have our work cut out for us. And it is our pleasure to bring to you Dr. Elizabeth Zehng. Dr. Zehng is a transplant hepatologist who cares for patients with liver diseases, including hepatitis B and liver cancer. Dr. Zehn's research is focused on finding ways to increase access to liver care for the underserved patients and on developing strategies to increase screening for liver cancer. Dr. Zehng earned her medical degree at New York Medical College. She completed her residency in internal medicine at Montefiore Medical Center, an affiliate of the Albert Einstein College of Medicine, a fellowship in gastroenterology at Einstein Medical Center, and a fellowship in transplant hepatology at UCSF. Very lucky to have Dr. Zehng. And we also want to recognize VBI Vaccines, who is our program support partner for this program. So without further ado, welcome, Dr. Zehng. We appreciate your time and expertise to educate us all today.
Thanks so much, Susanna. And thank you to the Community Liver Alliance for inviting me and allowing me to talk about one of my favorite topics in liver disease, which is hepatitis B. I hope you can all see start off with hepatitis B. We'll talk about the epidemiology of Hep B, how we can prevent Hep B, mostly through vaccination, how we diagnose hepatitis B and the different phases of infection, and then lastly, how hepatitis B can be managed. And then I'll end the presentation with co-infection with hepatitis D. So how we diagnose hepatitis D, the clinical course of Hep B and Hep D co-infection, and how we might manage both of these viruses. So just to start off, hepatitis B is really a global problem. And just a reminder for everybody, the definition of chronic hepatitis B is the presence of hepatitis B surface antigen for greater than 6 months. And so if we look across the world at hepatitis B surface antigen prevalence rates, we see that certain areas of the world have higher hepatitis B prevalence than other parts. So in the darker blue, we see certain areas in Central America, Africa, as well as Asia have higher hepatitis B surface antigen prevalence. And if we look at us in the US, we see that we have relatively low rates of hepatitis B. But worldwide, about 240 million people are infected, and about only 1.7 million people are undergoing treatment. And so because this has such a global burden, hepatitis B has been one of the kind of targets for the CDC and the WHO to eliminate the virus completely. And so in 2022, the CDC put out kind of a progress report to see how we're doing in actually eliminating hepatitis B. So we're doing pretty well in terms of meeting metrics on two fronts. So we're able to reduce the estimated new hepatitis B virus infections, and we've been able to reduce the reported rate of new hepatitis B virus infections among persons who inject drugs. And so this really goes to show that our efforts in prevention through vaccination has been helpful. But what we haven't been able to do is reduce the reported rate of hepatitis B related deaths, and we haven't been able to reduce the reported rate of hepatitis B related deaths among Asian and Pacific Islanders. And this kind of highlights the fact that we still have a lot of work to do in terms of diagnosing patients and then linking them to appropriate care. If we look at hepatitis B in the US, looking at population data, we know that it's still underdiagnosed and it's more prevalent among certain ethnic groups. So looking at population data from 2013 to 2016, an estimated 2/3 of US adults who were living with chronic hepatitis B infection were actually unaware of their infection. And then when we look at data from 2013 to 2018, we see that the majority of people with chronic hepatitis B, so 69.1% of people with chronic hepatitis B were actually non-US born. And so these people are about 9.1 times more likely to have infection compared to US born persons. And then among those, about 610,000 non-US born residents with chronic hepatitis B, the majority of them were Asian, so 69.7%, and 13.7% were Black or African American. And so knowing that hepatitis B is underdiagnosed, it has a significant global burden, and it has a lot of downstream effects, which I'll go into. I kind of want to focus on what exactly is so intriguing about hepatitis B itself. So it's somewhat of a tricky virus. It's a double-stranded DNA virus, and it's tricky because once it gets into the hepatocyte, it can incorporate itself into the nucleus of the hepatocyte, and it can be converted into something called cccDNA. The tricky thing about hepatitis B is that once it's converted into cccDNA, that makes our current treatment options very difficult to kind of eliminate hepatitis B. So our current treatment options have very limited effectiveness against cccDNA. And so hepatitis B can kind of hide itself in the hepatocyte. And that's really what makes hepatitis B very difficult to cure. So once someone actually develops chronic hepatitis B, I'll go into, again, the consequences of chronic hepatitis B. It's very, very hard to eliminate. So it makes sense that a lot of our efforts now are actually based on prevention through vaccination. I wanted to show this slide because it can kind of depict, that hepatitis B is associated with a severe burden of downstream disease. So this shows us the 5-year cumulative incidence rates for the development of chronic hepatitis B complications. And so here we start off with a normal liver. Patients get chronic hepatitis B, and those who have chronic hepatitis B have an increased risk of developing cirrhosis. And from there, they have an increased risk of developing hepatocellular carcinoma, or HCC. And what's unique to hepatitis B is that you can actually develop HCC even in the absence of cirrhosis, which makes diagnosing and treating hepatitis B even more important. But before we go into diagnosis and treatment, I want to highlight a few ways to prevent hepatitis B. And namely, the prevention of hepatitis B is really based on vaccination. So hepatitis B vaccines first became available in the 1980s. So it's been around for a while. And since then, the global vaccination rates have increased greatly. So countries such as the US have adopted a vaccine program in which all newborns here receive the hepatitis B vaccine. And these vaccines over time have been proven to be safe and effective. And the recombinant hepatitis B vaccines actually have a response rate of greater than 90%, so very effective. Currently, all adults who are 19 to 59 are recommended to undergo vaccination against hepatitis B, regardless of what their risk factors are. And then older adults who are at least 60 years old with risk factors should be vaccinated. But that's not to say that if you have a patient who's 65, has no risk factors, and want to be vaccinated, shouldn't be offered vaccination. I wanted to use this slide to kind of show the different types of hepatitis B vaccines that are now available, and to kind of show the options people have in terms of how quickly they want to finish the vaccine series. So there is a 2-dose vaccine series, so people can get vaccinated against hepatitis B as quickly as 1 month. And then there are 4-dose vaccine series. And also, if you want to get vaccinated against hepatitis A and hepatitis B, that's also possible. Just a couple of vaccine updates. So the Hepatitis B, which is an adjuvant 2-dose vaccine, is now recommended for all adults in the US. So again, this is a 2-dose vaccine series given at time 0 and then 1 month later for anyone who's at least 18 years old. And this vaccine is very effective. If you looked at patients who got this vaccine, you'll see that they all developed, or at least 90% of them developed anti-hepatitis B surface antibody. The newest hepatitis B vaccine looks to be the most effective, and it's being recommended by the Advisory Committee on Immunization Practices. So the newest hepatitis B vaccine is called Heb B, and this is superior to the monovalent Interjex B vaccine at 91 versus 77% overall effectiveness after 3 doses, which is different than the Hepatitis B, which is given at 2 doses. Unfortunately, there's just not enough data at this point on Hepatitis B and Heb B for pregnant women. So if you have a pregnant woman who needs to be vaccinated, it's still recommended that they get Interjex, Recombavax HB, or Twinrix. Now, I'm sure that you've vaccinated many patients against hepatitis B, and many of those patients don't need post-vaccination monitoring, but you can check a response to vaccination about 1 to 2 months after they complete the series among people who you think are very high risk for exposure to hepatitis B. So, for example, healthcare workers, people who are undergoing dialysis, immunocompromised patients, sex partners of hepatitis B surface antigen positive patients, and newborns of hepatitis B surface antigen positive mothers. If you find that these patients have no response, you can repeat the second series and then retest for immunity about 1 month later. And then if you find that they still don't respond even to the second series of vaccine, those are patients who should be checked for hepatitis B surface antigen and anti-hepatitis B core antibody, just to make sure that they themselves do not have chronic hepatitis B or have been exposed to hepatitis B in the past. Now, I wanted to show some inspiring data about hepatitis B vaccination and mass screening. And so this was conducted on a much smaller scale amongst Alaska Native communities. And what they did was they had a mass screening campaign that started in 1981 to screen for hepatitis B. And then they also started a vaccination campaign in 1984 to vaccinate children and all other people who were not immune to hepatitis B. And they followed them over the years to see how that affected the prevalence of chronic hepatitis B, as well as the incidence of HCC. And we see that as soon as they start their mass screening campaign and their vaccination campaign, the prevalence of hepatitis B surface antigen goes down significantly. And you see that this is a long-lasting effect well after the vaccination and the mass screening campaigns are initiated. And the loss of surface antigen within this community, or essentially cure of hepatitis B or elimination of hepatitis B in this community, is also reflected by the fact that these children also are not getting HCC anymore. And so again, this is a very small scale compared to what we're trying to do across the world, but it does show that this can be done. And hopefully one day we can actually talk about, completely eliminating hepatitis B. So now I just want to shift gears to diagnosing hepatitis B and then talking about treatment for hepatitis B. So again, chronic hepatitis B is defined as the presence of hepatitis B surface antigen for at least 6 months. And it's important to note that the risk of chronic infection is related to the age at infection. So the younger you are when you get infected, the more likely you are to develop chronic infection. So about 90% of infants who get hepatitis B will develop chronic hepatitis B, as opposed to adults who get hepatitis B. So about only 2 to 6% of people who get hepatitis B as adults will actually become chronically infected. And that's mostly due to the fact that adults have much more robust immune systems that can fight off hepatitis B as opposed to infants. Now, who should you be screening for hepatitis B? This is a long list based on CDC guidelines, and I definitely don't want to read off this slide to you. So this can be found under the CDC website for hepatitis B. And I'll also share my slides so you can refer back to this to see exactly who needs to be screened for hepatitis B. So now let's focus more on the diagnosis of hepatitis B. And this, I want to, again, say that this is screening for chronic hepatitis B. This does not include diagnosis or management of acute hepatitis B. So when you want to screen someone for chronic hepatitis B, I usually just check all of these labs right off the bat because, the more information, the better. So the first lab is obviously the hepatitis B surface antigen. I will also check for hepatitis B core antibody, which can be ordered as total antibody, and that includes IgG and IgM, or you can just check the hepatitis B core antibody IgG. And then the last piece of information that I'll check initially is hepatitis B surface antibody. If you have somebody who screens positive, so positive hepatitis B surface antigen, then that usually means that, this is quite accurate. And so that usually means that this person does have hepatitis B. So the next set of labs that you'll want to obtain is a hepatitis B viral load, hepatitis B E antigen, because E antigen can tell us if the virus is replicating actively. We'll also want to get E antibody and then also a set of liver tests. Patients with hepatitis B often have co-infection, and so it's important to check for co-infection with hepatitis C, HIV, and hepatitis D. And also patients with chronic hepatitis B likely have had the infection for a long period of time. And so we know that infection with hepatitis B can increase the risk of developing advanced levels of fibrosis or cirrhosis. So staging of fibrosis in these patients is important. And then lastly, counseling them on transmission of hepatitis B, what to do if pregnancy is an issue, and if they need to be screened for HCC. If you have a patient who screens negative for surface antigen, but you find that they have positive hepatitis B core antibody, regardless of the fact if their hepatitis B surface antibody positive or negative, we know that as long as their core antibody is positive, that means that at some point they were exposed to hepatitis B. And again, because hepatitis B can hide within the hepatocyte as cccDNA, these patients always are at increased risk of reactivation, particularly when they undergo some sort of immunosuppression through chemotherapy, or if they're getting a B-cell depleting agent like rituximab. So these patients, there's not much to do with them unless they undergo treatment with immunosuppression, chemotherapy, or rituximab. These patients are the ones that need to either be monitored very closely for reactivation or just be started on medicine to prevent reactivation in these scenarios. And then lastly, the last set of patients are patients who are hepatitis B surface antigen negative and are also hepatitis B core antibody negative. So these are patients who have never been exposed to hepatitis B, who do not have hepatitis B. And in this scenario, you definitely want to check a hepatitis B surface antibody, because if surface antibody is negative, you'll know that this is the perfect opportunity to counsel these patients on vaccination. So once you've diagnosed a patient with hepatitis B, the next step is kind of trying to figure out the phase of hepatitis B infection they're in. And this really helps to kind of determine whether or not they need treatment, and also helps to predict what the future might look like for them in terms of hepatitis B management. And so again, this is looking at a patient with chronic hepatitis B, and we're kind of following them over the years. And so assuming that they get infected with hepatitis B at birth, so time 0, and then following them over the years as they get older. When they're younger, usually between birth and up until their 20s, they're in this immune tolerant phase where we see that the hepatitis B viral loads are very high and the ALT is low or normal. And so you can kind of remember this as the liver being very tolerant of hepatitis B at this point. And in this early stage of infection, these patients are usually hepatitis B e antigen positive. And so again, e antigen positive just means that the virus is actively replicating. So it would make sense that in this phase, the hepatitis B viral load is very high. As you follow these patients as they get older in their 20s to kind of their 30s, 40s, they will all go into this immune clearance phase in which their immune systems are getting stronger and the liver is kind of fighting back. And so in this stage, you'll see that the ALT can start to rise. And as the ALT rises, you can see the hepatitis B DNA viral load starts to fall down. If you monitor these patients very closely, you might see that these levels kind of fluctuate in between as well. And this is the immune clearance phase, in which you'll also see that e antigen positivity can become negative, and these people can start to develop e antibody. And so they may be e antibody positive by the end of this immune clearance phase. And it's in this phase that treatment should be started. If we miss this phase and these patients get older, we might find them in an inactive carrier state. And so in this inactive carrier state, when most of them have already developed hepatitis B e antibody positivity, we see that the viral load for hepatitis B is low, and we see the ALT levels also come down to normal or low. In this stage, treatment is not indicated because it hasn't been shown to provide any benefit. And then as we continue to follow these patients into their 60s and their 70s, they have an increased risk of developing reactivation. And so if you're following them closely, you might see in this period, again, the ALT and the hepatitis B DNA viral loads start to fluctuate and increase. And in this later stage of infection, treatment may also be beneficial. So, the different phases of hepatitis B infection kind of, as you can see, is up and down. And so that really kind of also shows that management of chronic hepatitis B is very multifaceted. And so it requires monitoring many different components. And so that includes staging of fibrosis, and then also continuing to follow these patients through their different phases of infection. It's very dynamic. And so the decision to treat, you may not treat a patient 1 year, but then 5 years later, you might find that they do need treatment. And then some patients may need hepatocellular carcinoma or HCC surveillance because they're at an even increased risk of developing cancer. But regardless of which phase, if they're stable or not, all patients with chronic hepatitis B do need lifelong monitoring. I just want to talk a little bit about staging of fibrosis, mostly because this is such an important part of managing patients with hepatitis B. A really important piece of information to have before you start treatment, because it can guide your treatment, and then it can guide what you might want to do with these patients in the next 10, 20 years of their lives. Fortunately, we've come a long way with staging of fibrosis. And so right now, we rely mostly on non-invasive methods of staging of fibrosis. So you can do point of care testing, which is calculating a Fib4 score or AST to platelet ratio index by using just platelet counts as well as liver tests. So this can be easily calculated just based on routine blood work. You can get some more specialized serum testing through a fibro test or FibroSure. And then many times, if your facility offers it, we have been doing elastography to stage fibrosis. So whether it be through a FibroScan, which is vibration-controlled transient elastography, or shear wave elastography with ultrasound, or getting an MRI with elastography, there's many different options now for non-invasive staging of fibrosis. And then lastly, if you're not sure, or if you don't think that your testing has been accurate, you can always go for the invasive method, which is a liver biopsy. And a liver biopsy can tell us a lot of what's going on in the liver, and it's also the most accurate in terms of staging of fibrosis. So once you've kind of determined, if your patient has hepatitis B, which stage they're in, and which stage of fibrosis they have, then you're kind of better informed in terms of actually potentially treating them for hepatitis B. And so I always kind of refer back to this algorithm when I want to consider starting treatment for hepatitis B. So if you have a patient with chronic hepatitis B and they have cirrhosis, hands down, whether or not they have a high viral load, a low viral load, or a normal ALT, as long as they have cirrhosis, they need to be started on treatment. If they don't have cirrhosis, then you can split these patients up into E antigen positive versus E antigen negative. And so again, when somebody is E antigen positive, that would mean that they're at that they're actively replicating virus. So you would actually expect their hepatitis B DNA viral loads to be rather high. So amongst these patients, if they have a high hepatitis B DNA viral load, but a normal ALT, you can monitor them safely about every 3 to 6 months to make sure that, again, their ALT level stays normal. But if they're a little bit older, so if they're older than 30 to 40, or if they have a family history of cirrhosis or liver cancer, you could consider counseling them on starting treatment. The patients who definitely need to be started on treatment are those who have high hepatitis B DNA viral load. So in this situation, greater than 20,000, persistently elevated ALT level. These are patients who would benefit from treatment. And I'm sure you might find that there are a lot of these patients that are kind of in between. So not very high viral loads and slightly elevated ALT levels. So these patients could potentially be monitored if you find that they are reliable enough to undergo close monitoring. And that can also allow you some time to evaluate for other causes of elevated ALT, maybe fatty liver, maybe they have co-infection with another virus. The second group are patients who are E antigen negative. And so these are patients who are not actively replicating virus. And so you would expect that naturally that their hepatitis B viral loads are lower. And so if they have a low hepatitis B DNA viral load and a normal ALT, you would want to monitor them every 3 to 6 months. But if they have a higher hepatitis B viral load, in this situation, more than 2,000, and a persistently elevated ALT, then you would want to start treatment in these patients. Again, if you have somebody that's kind of in between these stages, and you find that they are very reliable in terms of monitoring, you could use that time to also evaluate for other causes of elevated ALT. And so I mentioned before that treatment of hepatitis B does not necessarily mean we can actually eliminate hepatitis B. So when I start somebody on treatment, it's important to kind of manage their expectations. And so even though treatment of hepatitis B doesn't eliminate hepatitis B or cure hepatitis B, the whole point of hepatitis B treatment is really to suppress the virus. And we know that viral suppression overall can reduce liver-related mortality, and it can reduce overall mortality. So there, even if we cannot cure hepatitis B, there are great benefits of treating for hepatitis B and suppressing virus. Specifically, viral suppression has led to decreased inflammation and fibrosis. It decreases the progression of fibrosis stages. And amongst patients who had advanced fibrosis or cirrhosis, we see that treatment can actually reverse stages of fibrosis and cirrhosis. And it can also potentially reverse decompensation in patients who have decompensated cirrhosis. And then viral suppression can also reduce the risk of developing HCC. Now, again, when counseling patients on treatment with hepatitis B, many of these patients, unfortunately, because it doesn't cure hepatitis B, many of these patients are on Hep B treatment long-term, if not lifelong. But there are special populations of patients with chronic hepatitis B who only need finite periods of treatment. One special population are pregnant women. And so treatment of hepatitis B for pregnant women is really to prevent perinatal transmission. So if you have a patient with chronic hepatitis B and your patient is pregnant and you monitor their viral loads, particularly in the third trimester, and see that it's quite high, so over 200,000, then antiviral therapy should be initiated. Because this can significantly reduce the risk of perinatal transmission. You can potentially treat them up until the time of delivery or up to about 4 weeks postpartum. The treatment of choice is tenofovir disoproxil, which is highly potent and it has a high barrier to resistance. And amongst patients who choose to breastfeed, treatment with tenofovir disoproxil is also okay. The second special population are those who are immunocompromised. So if you have a patient who is normally very stable, chronic hepatitis B, but is going to be immunosuppressed for whatever reason, regardless if they're stable or not, these patients need to be put on treatment for hepatitis B to prevent flare. Amongst patients who are surface antigen negative, but are core antibody positive, these are patients you need to worry the potential for reactivation when they're immunocompromised. So you could, carefully monitor their ALT levels, their DNA viral loads, and their surface antigen. If these are patients who are very compliant and come in very frequently for lab work. And if these ever become abnormal or positive, then you could start them on treatment. But if you find that your patient is not very reliable in terms of getting this type of monitoring, and you worry that they increased risk of reactivation. So if they're getting rituximab or they're undergoing stem cell transplant, these are patients you should probably just put on prophylaxis to prevent reactivation of hepatitis B. So the preferred therapies for these populations is entecavir, tenofovir disoproxil, or tenofovir alafenamide. You would want to treat them for at least 6 months after immunosuppressive therapy stops, or at least 12 months after you stop anti-CD20 treatment like rituximab. Because even if you stop immunosuppression, they still have an increased risk of reactivation for about 6 months to 12 months. So you want to continue prophylaxis for a certain period of time. Now, we have several different treatment options available. I included all the first line therapies at this point. And even though PEG interferon is technically a first-line therapy, it's really not widely used. One, because it's not very easy to tolerate for patients. It requires a lot of monitoring, and the compliance rates for interferon are much lower, as opposed to patients who are on oral medications that are taken once a day. So entecavir, tenofovir disoproxil, and tenofovir alafenamide are the first-line therapies that are oral treatments currently available. Tenofovir alafenamide is the medication that was most recently approved, and this is a prodrug of tenofovir disoproxil. So it doesn't have the renal side effects and it doesn't have the bone side effects as tenofovir disoproxil. Unfortunately, it's much more difficult to get from certain insurances, but if you have a patient who has any sort of renal insufficiency or any sort of bone health issue, you could use that to make a case to get these patients tenofovir alafenamide. Now, once I start patients on treatment, one of the first questions that they ask once they start is, when can they stop treatment? And so, again, it's important to kind of manage expectations for patients when you first start them on treatment, because most patients, once they start, need treatment for long-term, if not lifelong. The patients that always need treatment are those with cirrhosis and those who are immunosuppressed. So you can, if you have a cirrhotic patient with hepatitis B, you can kind of just tell them that they will be on this medicine forever. The discontinuation of treatment should be based on each individual and their own risk of reactivation. And so, realistically, most patients don't want to be on long-term medication. And so there's some potential treatment endpoints that if they hit these endpoints, you could consider counseling them on stopping treatment. So the first group are patients who have been on treatment and you're able to suppress their viral loads, so they're less than 10 or not detectable. You see that their ALT is persistently normal, and you see that while they're on treatment, they were initially E antigen positive, and while they've been taking treatment, they become E antigen negative, and they seroconvert to E antibody positive. So this is kind of like the best case scenario, the most realistic scenario for most patients. If they hit these endpoints, you could consider a period of consolidation, so just continuing them on treatment for another 1 to 3 years and then stopping treatment. I will say, though, that these patients should be counseled that losing surface antigen, so actually curing hepatitis B in this situation, is very low. And if we follow most patients over time, most of these patients actually need to be put back on treatment. So the chance that they'll need to be put back on treatment is pretty high, but again, you could give them a chance to stop medication. The other scenario is if you don't know what their E antigen status is when they start treatment. So for example, if they were already E antigen negative when you started treatment, it doesn't really matter. So then, your only endpoints would be if you suppress virus and you have a persistently normal ALT, typically for at least a year, you could consider stopping them on treatment. But again, they should know that the majority of patients who stop treatment at that point will go back on treatment. And then lastly, I want to talk about screening for liver cancer, or HCC. So this is based on the AASLD guidelines of who should be screened for HCC. So basically anybody with cirrhosis of any etiology should be screened for HCC. And then any person who has chronic hepatitis B, who is an Asian or Black man over the age of 40, an Asian woman over the age of 50, a person with a first-degree family member with a history of HCC, or anyone who's co-infected with hepatitis D. These are people who need to be screened for HCC because they carry a higher risk of developing HCC as time goes on. And so screening usually entails an ultrasound with or without an AFP level, although I would say definitely check an AFP level because it increases sensitivity for screening. And you want to check ultrasound and AFP every 6 months. Among patients who get an ultrasound, but the imaging is suboptimal, whether it be due to body habitus or, if there's too much bowel in the way, you might want to consider doing a CT or MRI instead of ultrasound as screening. And so now I want to shift gears a little bit to hepatitis D, which is a co-infection of hepatitis B, meaning that hepatitis D needs hepatitis B surface antigen to replicate. And so infection can occur in one of two ways. One is you can get simultaneous co-infection with hepatitis B and hepatitis D at the same time, or you can already have hepatitis B and then you can get super infection with hepatitis D. This is usually transmitted by blood or sexual contact, and fortunately, vertical transmission of hepatitis D is quite rare. Hepatitis D prevalence, just like hepatitis B prevalence, varies across the world, and in certain regions are much higher than others. So in the dark red, we see Mongolia, Russia, areas of Africa and Central America have a much higher prevalence than other areas in the world for hepatitis D. So diagnosing hepatitis D can be a little bit more difficult, mostly because many mainstream labs don't have the ability to actually diagnose hepatitis D. But if you have a patient with hepatitis B or chronic hepatitis B, you should check their hepatitis D antibodies, so hepatitis D IgG. If this becomes positive, it doesn't actually mean that they have active hepatitis D. It could just mean that they had active infection many years ago, and this antibody is just lingering. But if they do screen positive for hepatitis D IgG, you can confirm that with hepatitis D RNA. And again, this is not offered by every commercial lab, but it is now being offered at Quest. So that hopefully makes it a little bit easier to diagnose hepatitis D. And then amongst patients with co-infection with Hep B and Hep D, many of these patients actually often have co-infection with Hep C and HIV. So definitely making sure that you're checking for hepatitis C and HIV. So the clinical course as to how they get co-infection can vary. So if you get co-infection with hepatitis B and hepatitis B at the same time and it becomes an acute infection, most of the time in these situations, you can clear virus. And in rare cases, fulminant liver failure can occur. And then amongst patients who have chronic hepatitis B, but then they get hepatitis D superinfection, in these situations, unfortunately, Hep D can rarely clear spontaneously. And so these patients, unfortunately, have a very aggressive co-infection with Hep B and Hep D. And so we see that they can have accelerated fibrosis progression, an increased risk for HCC, earlier decompensation, and overall reduced survival. Unfortunately, for acute infection for hepatitis D, we don't really have any specific treatment. And that's mostly because for the majority of cases, supportive care is enough. And most patients are able to kind of get rid of both acute hepatitis B and hepatitis D on their own. The use of foscarnet has been reported, but this is not widely used. If you have a patient with chronic hepatitis D infection, and you're able to confirm that with positive RNA, then you might want to treat them, especially if they have active hepatitis or elevated liver tests. But in these situations, I usually treat hepatitis B first. And if you're able to treat hepatitis B and get the liver test normal, you may not need to go ahead with Hep D treatment, which is much harder to do. And that includes treatment with PEG interferon for a year. We don't really know what the optimal treatment is, but PEG interferon is more favored. And the primary endpoint of treatment is making sure that you suppress the RNA virus for 24 weeks after you complete treatment. And there's been some studies that have been shown some benefit when you use certain antivirals for hepatitis B, like tenofovir and adefovir. And so I just wanted to wrap up, with some future considerations. Hopefully, if I give this talk again in 10 years, I'll be talking about an actual cure for hepatitis B and not just viral suppression. And so most of the studies now are looking at two main categories of therapy. One is looking at direct acting antivirals, so similar to hepatitis C cure. And then another type of therapy is looking at immune response targets, how we can modulate the immune system to kind of fight against hepatitis B. And so there's several phase 1 to phase 3 medications that are being looked at right now. And they're mostly being looked at to see how they can reduce surface antigen, because if we get rid of surface antigen, then we're actually curing hepatitis B. There's still a lot of hurdles to overcome. So we need to find the right drug for the right patient population. What's most important, obviously, is safety. And then also making sure that we can sustain a response. So even if we lose surface antigen, it's important that we can continue to lose surface antigen and that it doesn't come back. And then also seeing if there's any good combination strategies. But at least at this point, it looks like there is definitely hope for an actual functional cure in the future. And again, just some challenges with the current hepatitis B treatments that are available. So even if you start someone on treatment, you very infrequently get surface antigen loss. It happens at a very low rate. And people who have inactive hepatitis B are, can clear surface antigen at the highest rate, but even 2 to 3% per year is not very high. So most patients will require lifelong therapy. And then there's certain groups that right now, treatment is not recommended. So patients like the immune tolerant patients and the inactive chronic hepatitis B patients. But it would be interesting to see that if we actually treated them, could they lose surface antigen earlier? And does that actually have a clinical significance? So just to conclude, hepatitis B remains underdiagnosed, and we need to do a much better job in terms of screening and linkage to care. And if we really want to eliminate hepatitis B, we need to definitely help in the effort in vaccination. When somebody has hepatitis B, it's always important to check for co-infection with Hep C, Hep D, and HIV. A positive surface antigen means that this person is infected with hepatitis B. And so the next set of labs should include e-antigen status, hepatitis B viral load, and an ALT level. as well as trying to estimate their stage of fibrosis so that you can determine if treatment is required. And then certain patients who are at highest risk of developing liver cancer need to be screened for HCC. When counseling patients on treatment for hepatitis B, it's always important to let them know that really the treatment is to suppress viral load. But the benefit of suppressing viral load is that it can reverse fibrosis and it can prevent HCC. But unfortunately, cure is very rare. So surface antigen loss is very rare. And then lastly, hepatitis D co-infection can occur. So hepatitis D requires the presence of hepatitis B surface antigen. So if you have a patient with Hep B, always check for hepatitis D IgG. And if that's positive, you would want to confirm that with an RNA. And unfortunately, there's no optimal treatment for hepatitis D, but in a lot of cases, you can treat just for hepatitis B, just to at least get the inflammation and the ALT level down. And so that concludes my talk for hepatitis B and hepatitis D. I hope you learned something in this brief review about these two very important liver viruses.
Good. Thank you so much, Dr. Zehng. We really appreciate your time and your expertise.
Oh, of course.
Thank you to everybody who participated and attended. If you do have any additional questions, please type in the chat. We can moderate that for a few minutes. Additionally, if you look in the chat, there is a link to a survey that we'd all like you to participate in. It just gives us an overview of what you got from this presentation and what you'd like to see in the future. So again, thank you to our attendees. Thank you to our sponsor, VBI. Without them, we can't provide educational experiences like this. And thank you once again, Dr. Zehng. We greatly appreciate it. Thank you all and have a good night.
No problem. Thank you. Good night, everyone.